All right, welcome back to school, everyone, for this short visit before you head out on your clinicals. This is just going to be a brief review of documentation principles that you've already learned, just to remind you of the things that we need to be doing when we're documenting so that when you're doing this in your clinical rotations, you're doing it well. So let's get started. So here's a quick overview of the principles we'll be discussing. First, I want to help you keep the big picture in mind, that your documentation should illustrate the data that you've gathered and why it's important. So it should illustrate your clinical reasoning. Secondly, we want to discuss using templates and checklists to ensure that your documentation is thorough and organized. Third, we'll talk about defensible documentation and how best to make it defensible. And finally, I'll just remind you of some of the resources that are available to you so you can create high quality documentation. So first, your documentation should illustrate how you clinically reasoned through the process from gathering data to evaluating that data and then creating a plan of care. We have the ICF model that helps us do that very easily, and you guys have practiced using that. So your documentation, when it's finished, should show a clear progression from the data that you gathered and what impairments the patient's experiencing based on that data, to the specific activities that are limited because of those impairments, and then on to how each specific activity limitation is affecting that patient's ability to participate in life situations that are important to them. In other words, participation restrictions. And finally, your documentation should show how the interventions that you've chosen will resolve the impairments and limitations that you have discussed in your documentation. And all of this should flow naturally from your goals. So when you ask your patient for their goals in therapy, you should already be forming ideas for the end result of that clinical reasoning, and it should be reflected in those goals. So now let's take a look at an example of this flow of clinical reasoning throughout a piece of documentation. So in this example, we'll follow a 65-year-old female with right knee OA who came in for a physical therapy exam. So let's start by looking at just the first entry in each of the ICF categories. So you can see under impairments, the first impairment listed is a flexion range of motion limitation. And this leads to difficulties with prolonged sitting in the next box, and then it leads to a restriction in participation for sewing. So then you can see in the next box that we chose some activities, some interventions that would help with improving range of motion, including flexibility and joint mobilizations. And then we have a goal related to that impairment. Resume sewing for 60-minute bouts. So it reflects not only the relevance to the patient, but the relevance to all of the impairments and limitations that we discovered in our exam. The other entries should have a similar flow. So the second entry shows decreased quad strength, and that leads to a difficulty with sit-to-stand transfers, so that's our activity limitation, and that makes it difficult for the patient to perform personal hygiene like toileting and bathing. And then we would use interventions such as strengthening and endurance training to decrease that impairment, and our documentation should make it very easy for any consumer of that documentation to see this progression from impairments and limitations to interventions to goals. And so if we don't see that logical flow, we need to do a better job of documenting. So the next step is, where do we put each of these entries in our documentation? So where should it be located? Well, fortunately, we don't have to come up with that answer ourselves. We've got plenty of documentation resources that we can go to. There are a number of different formats that we can use to organize our data, but these formats will typically be constrained by whatever EMR you're using, and you've probably experienced that in your first clinical rotation. So it's not as important which framework you use as it is to actually use one and use it effectively. So even if you're in an EMR that requires certain entries, you should always be thinking through a framework that makes sure you're including all of the pertinent information. Our guiding document to help us with organizing our data in this way is the APTA Board of Directors document that basically lists the required information for each type of patient encounter, including an initial evaluation, a routine visit, a re-exam, or discharge. We also, in our patient management course, if you remember, talked about the SOAP format as well as the SERP format. So those are just some ideas of different ways to organize your data. But again, just make sure that however you do it, that you're following those professional guidelines in that APTA Board of Directors document. So when you learn and use these categories, you'll ensure that your documentation is following the professional standard of care adopted by the APTA. And if you're ever in a litigation situation, this is the standard of care that they'll look at, and they'll expect your documentation to follow this framework. So let's continue with the case example we just used in the previous slide to see how the information would look in this framework. First, the history. So I'm under examination there. The first part of the examination is history. Participation restrictions and activity limitations are included in this. We listed what the patient feels is limited, including sewing, toileting, and shopping. And you can typically find out about these limitations even before you find out about impairments, because you're doing it in the interview. So you'll have to make the progression obvious in another part of your note. That's typically going to happen in your assessment portion. But finding out about limitations and restrictions in your interview first will help you start forming hypotheses as to what impairments you might need to look for in your exam. Of course, you'll do a systems review to screen the rest of the body and make sure there aren't other things you need to be looking for, and then you'll move into your tests and measures. So in our example, the impairments that we found in our tests and measures included range of motion measurements, strength measurements, balance assessments, and identifying comparable signs. Then we move into the evaluation portion. This section is where you'll make that connection from impairments to activity limitations and participation restrictions. You can do this with a problem list and personal and environmental factor assessment, and then you move into your physical therapy diagnosis of impaired mobility due to OA for this particular patient. Then our prognosis would be where we show the impact of therapy on the patient's goals. So you'd expect them to reach that functional level of resuming sewing and shopping independently within a certain time frame, like 8 weeks. And that's where your goals would come into play to show that logical progression. And then finally, the plan of care. And this should include your goals that we've already discussed, but also a list of general interventions that you think are going to be necessary to reach those goals, how often you'll see them and for how long, and then discharge plans that show the functional level they should reach before you discharge them, and again, the prognostic statement of how long that will take. As with the initial evaluation, the APTA Board of Directors document also gives us guidance on what should be included in a routine visit note. So where do you think each of these categories would fit in the SOAP format? We've got, or in the SERP format. We've got the self-report, we've got interventions with specific parameters that should be included in that documentation. We've got changes in impairments, limitations, and restrictions, responses to our interventions, including adverse reactions as well as positive ones, factors that could modify the frequency or intensity of intervention, and the progression towards goals, and also should include an adherence to home exercise program and recommendations. We also should include communications with other providers, the patient and the family, and then finally our plans for the next visit. So each of those categories listed down there at the bottom of the slide are the required categories for routine visit documentation according to the APTA. It's up to you to figure out how to organize those and what parts of your framework you should put them in, whether you're using SOAP or SERP or some other format. A lot of EMRs will use the SOAP format, so it's good to get familiar with that one. So before moving on from this slide, I would take a moment to at least go through the SOAP format, subjective, objective assessment, and plan, and quiz yourself on which of these categories would go in which part of the SOAP format. Once you've done that, go ahead and start the video again. Okay, now we're going to shift gears a little bit and talk about defensible documentation. So if you remember, the reasons that we want our documentation to be defensible is that it makes for good communication with the other providers in the healthcare team. It protects us from a legal standpoint, so risk mitigation is another purpose. And then finally, it helps us show the skilled need for our services, and that justifies payment. While it's pretty easy to see the purposes and the reasons for making our documentation defensible, it's another story to actually do it and make our notes defensible. So this gives you some guidelines on doing that. The first one there, using correct grammar and spelling. If it's not clear what your meaning is, then it's not going to be clear whether or not you're following the standard of care. So make sure you're using good grammar and spelling and rechecking anything that you dictate in an EMR. Next, we need to clearly show the necessity for skilled PT. So what is it that made your service skilled? Make sure that you get that in your documentation, whether it's cueing, an instruction, or other things that you're doing that no one else could do. Next, what factors could support your duration and frequency? So this, we're looking at the natural history of the disease, the patient's adherence to their home exercise program, comorbidities or other environmental issues that could be playing into the prognosis. And this should look familiar, and you should be able to see how this fits into that ICF framework. So again, if you use ICF, you cover a lot of the things that you need to cover to make your notes defensible, including the next bullet there, linking your plan and goals to functional deficits. That should be a natural progression if you use the ICF model as your framework. Next, being specific. So your intervention should show specific parameters as well as rationale for why those are being used, and showing the skill level needed to perform those again. Next, addressing progress. This is an important one for payers. So you need to show lack of progress with an explanation of why, or progress and show how it links to their progression towards goals. Comparable signs are a really great way to show the effectiveness of your treatments, and so that's a good way to demonstrate the skilled need. And then finally, make sure that you address anything that the patient told you and how they responded to your treatment. So all of these things should be incorporated into a note if you want to make it defensible. Here is a quick example of non-defensible versus defensible documentation for gait training. So the non-defensible note just basically says that they walked in parallel bars with Min Assist. That really doesn't give a lot of information about the skilled service that was provided. In the defensible note, you can see that it does. So it states basically that they ambulated, but then they required Min Assist for specific reasons: advancing the right lower extremity, manually facilitating pelvic stabilization during the stance phase. Then it talks about cueing, and not just that cueing was performed, but the specific cues that were required to make that ambulation effective. And then also talking about rest breaks required, and that will provide some rationale for the length of treatment and for the need for more treatment because they're fatigued and they don't have good endurance. So this is a good defensible note on gait training. Alright, so just to recap some of the main principles that we've discussed. First, we should use a framework, and I would suggest ICF, to clearly show our clinical reasoning, to illustrate that logical thought process from the interview to the exam to the evaluation and the plan of care. Second, we should be organized in our documentation. Use that framework to be thorough, but also be concise and organized in the way that we write our notes. And finally, make sure that we're providing sufficient detail to show the skilled need and to be defensible in our documentation. So I mentioned at the beginning the importance of using the resources that are available to us, and we talked a lot about that first one, the APTA Board of Directors documentation of patient-client management. That really provides the standard of care for our documentation. We also have a standards of practice document through the APTA House of Delegates. And then you can also go to other sources, like WebPT has a great defensible documentation toolkit that's provided for free. You can use evaluation templates and checklists that you create yourself or created for you in an EMR. And then there are also other APTA resources available to you, and I've provided the website there. But just make sure that you're using those resources so that you are providing good, high-quality documentation. Okay, so just a few parting thoughts, things that I'd like you to take home from this. First, while it's rare to find a therapist who's excited about documentation, it should be viewed as a vital part of our practice. Doing it well can protect us from legal troubles, but it can also protect us and our patients in other ways. For instance, good documentation can protect our patients' interests by securing better insurance reimbursement for them, by showing the quality of care they received and improving communication between their care providers. It can help us provide higher quality care by forcing us to think through our clinical reasoning each time we see our patients. So that's one main thrust for providing good documentation. Second, we have lots of great guidelines to help us make our documentation thorough, and I just went through some of those resources with you. Use these, review them regularly so that you can ensure that you're following professional standards of care. And then finally, practice, practice, practice. As with any other aspect of physical therapy care, we should constantly be practicing better ways to document to make ourselves more adept at writing thorough notes while doing it quickly. So, thanks for listening. If you have any questions while you're out on your clinicals about documentation or anything else, please reach out to me, and best of luck to all of you.